check. It's a urine test, and it's a urine dipstick test, and it combines two other biomarkers, and both of them are directly in they directly indicate that tubules have been injured, not just pre-renal reversible rises in the biomarker. So there are newer tests available, and hopefully we'll start using them in the future. But you have to remember, just because you have a rise in creatinine, and we've all seen this before, someone when you started diuresing or you started ACE and ARB and your creatinine rises, doesn't mean that you have tubular injury at that point. Creatinine rise is delayed, right? So it's when the way I describe it to the trainees is that when you see the creatinine rise, you're looking at a time capsule. You're looking 2 to 3 days ago. And so why have kidney outcomes not improved over the 30, 40 years that we've truly been doing research in this area? It's because we're looking at a time capsule. We're looking, by the time the creatinine rises, we've missed the boat, right? We've missed our opportunity to change the outcome. There's one trial done at Pitt where they showed that there are potentially methods to reverse these outcomes to prevent worsening of AKI or to prevent AKI in the first place. But this involves vigilant urine output monitoring and hemodynamic monitoring and volume responsive assessments and things like that. So it's very labor intensive. And they also use more advanced biomarkers, right? So it's possible, but it's still very difficult to do things like that just because of this delay in the rise. Fluid therapy, so when you have a patient that comes in, let's say in sepsis, septic shock, and their creatinine has gone from 1 to 2.5, and they've gotten their 30 cc's per kg, and they've got an additional volume, and you see that the creatinine is 2.1 next day. It doesn't necessarily mean you've improved their kidney outcome and that their renal function. Obviously, you have to follow the urine output, but creatinine, just like anything else, can be hemodiluted, right? It can be diluted. And so that may just be indicative of you increase their overall just total body fluid volume. And that creatinine is diluted doesn't necessarily mean that the renal function improved, right? So that's something to remember. The last one, I'm not going to focus as much, but there are interlaboratory variations as well. So I've I've talked a little bit about the AKI in the ICU because that's kind of my focus. Um, but as far as like the AKI overall, like the frequency and the epidemiology has stayed pretty consistent over years and years and years, which is fascinating. We haven't, again, like I mentioned before, we've been looking at this for 20, 30 years, and these outcomes still are quite different, right? So when you look at AKI in the ICU, what are the incidences? So AKI developed in about 22% of the patients in the ICU. And I know you're not all intensivists, but I'm sure you have some ICU exposure as well. So this is important information probably. So, and out of them, stage one is about 0.3 to 50%, big range. And so this is kind of the overall kind of epidemiology of AKI in the ICU. So I won't focus on this as much, but kind of wanted to show you the distribution. And you can see like the odds ratio, right? Odds ratio of death as it changes from stage one, stage two, and stage three in the ICU, right? So it changes and increases over time. You probably take care of post-op patients. So if you look at as far as post-surgical patients, there are certain surgeries that you're almost guaranteed to have AKI. So for example, cardiovascular surgery, you are almost guaranteed to have some degree of kidney injury if it's a complicated surgery, right? So like there's probably routine cabbage surgeries that may not develop, but most like complicated cardiovascular surgeries, you're probably going to have AKI. Surprisingly, orthopedic surgery has a higher. I would have, if I had never seen this before, I would have said that abdominal surgery probably has more AKI than orthopedic surgery because oftentimes you have intra-abdominal pressure changes and things like that, which we'll talk about. But orthopedic surgery is usually second. And what's fascinating about this is that even though the overall incidence of AKI in each of these surgeries is different, the stages proportion wise still stay the same in all types. So stage one, stage two, stage three. So most of the time it's stage one surgery, stage one KDIGO, AKI, which typically it'll reverse over time and they'll get back their renal function as well. So what about urine output, right? So we focus a lot about the creatinine criteria. What about the urine output criteria? So I think one of the problems with using the urine output criteria is that it does oftentimes require some method to collect this urine in an accurate, consistent way, right? So if you can't use have the patient collect the urine or have an adequate nursing ratio to make sure that the patient is collecting the urine or some Pyrrhic device, you need a Foley, right? So like really intensive monitoring often requires a Foley. But the gist of this slide, the kind of the crux of this slide, is that when you combine urine output criteria by itself, as you look at it, as predictive of mortality and outcomes, it's not as strong as the creatinine criteria, but when you combine them, it is most predictive of death, right? So when you combine the creatinine and the urine output criteria, especially when the adjusted estimates, it's most predictive of death, and it's probably is the best C statistic. Essentially, the C statistic, if you want to think about it, it's just the consistency of this test, right? And so when you combine that, it's probably the best method to predict outcomes as far as AKI. And potentially, if we follow urine output, so urine output changes before creatinine does, right? So as we've already discussed. So that may be in the study I mentioned before with at Pitt. They followed urine output pretty aggressively, right? So consistently, not just Q shift, they were doing it much, much more frequently, right? Q2 to Q4 hours. So that's a big difference as far as following the urine output. So if you were to follow urine output much closer, that's potentially a method to improve renal outcomes. And essentially, if you're improving renal outcomes, you're improving overall outcomes, right? So because the AKI in itself alters the trajectory of every other disease state. You have a patient with ARDS and you somehow cause ARDS, and when the AKI happens in that patient, that person's mortality has increased significantly just by adding the AKI, right? Because when you have AKI, there's crosstalk, there's bio crosstalk between all the other organs, especially the lungs, right? So when the lungs are injured, it predisposes to kidney injury. When the kidneys are injured, it predisposes to lung injury, right? So there's more capillary leak and it predisposes to worsening ARDS. So AKI is something that we need to take seriously because it does alter the trajectory of every other disease process. This is the intensive urine output monitoring study I'd mentioned before. It's by Dr. John Kellum over at Pitt. And what they looked at was, it's a retrospective study. They looked at around 15,000 patients. 4,000 with intensive urine output monitoring. So what do you mean by intensive? It's more than Q shift, right? So you're talking Q2 to Q4 hour urine output monitoring. And so after adjusting for the urine output monitoring, they found that there was improved AKI detection, improved survival with those with AKI, and there was less fluid overload. And that makes sense, right? So because patients are getting fluid, but they're not putting out urine. What's the quickest way to figure out that is just you're essentially at that point, you're probably saying that this patient has ATN they don't have reversible disease that's responsive to volume. And so at that point, if you know at a higher frequency urine output checking is just more precision, and at that point you can quickly make a decision that less fluid is likely something that's necessary in this patient, right? So intensive urine output monitoring can potentially alter renal outcomes because again it changes quicker than your creatinine would. So let's talk about physiology, and I love physiology. And renal physiology particularly is just it's fascinating. And when you think about just kind of the concept of the afferent arteriole and the efferent arteriole and some of the mechanisms of autoregulation, once you understand it, you can see why the GFR changes with different interventions and mechanisms out there, right? So when you have normal perfusion, so over here at the top left in A, you have your afferent arteriole, you have your glomerulus, you have the glomerular tuft, you have Bowman space in there. Let me see, sorry, get a little clicker annotate thing. There So you have your Bowman space here, you have your glomerular tuft, and then you have your efferent arteriole. This overall mechanism is what's maintaining your GFR, right? And so let's say you went from normal perfusion to hypotension. So now you have a hypotensive patient, right? Now to maintain perfusion, the kidneys will alter both the local and overall just systemic hormonal mechanisms, right? So you can change the level of prostaglandins. So these prostaglandins locally will increase vasodilatation, but systemically you'll also have increase in angiotensin 2 as well. And so the angiotensin 2 has many, many mechanisms, but these prostaglandins will work just locally. And you'll have vasodilatation of your afferent arteriole. So what happens when you have the vasodilation of your afferent arteriole? You have more volume coming into these capillary tufts, right? And how does filtration happen? It's essentially the difference in your capillary pressure, your hydrostatic capillary pressure. Oncotic has very little involvement in this process, but your capillary pressure and the GFR is maintained by the hydrostatic pressure difference here in the capillary tufts and Bowman space. This Bowman space pressure is essentially zero. It's 0 to 5. This pressure is usually around 30 to 35. And so you can increase this hydrostatic pressure and you'll eventually get more filtration. You'll get, so these are semi-permeable, right? So you'll get more filtration and your GFR will increase, right? Now, if you, at the same time as your you have more vasodilatation of your afferent arteriole, you vasoconstrict your efferent arteriole. You can imagine that this concurrent process, you're going to have an increase in the hydrostatic pressure, and more your GFR will be maintained despite the decreased perfusion pressure. Now, this is why when you are on NSAIDs, this mechanism is impaired, right? So if you're on NSAIDs, this compensatory mechanism can't happen. You can't maintain this perfusion pressure because your compensatory mechanisms are altered. So when you have NSAIDs, you don't have as much production of these prostaglandins. So this vasodilatation of your afferent arteriole doesn't occur. At the same time, you do still have the increased angiotensin too. So you still have the vasoconstriction of the efferent, and you can kind of maintain the perfusion pressure if you were just on NSAIDs. Now, what about if you're on an ACE or NARB? This mechanism is not going to happen, right? Because you're blocking, like if you're on an ARB, you're blocking the angiotensin 2 mechanism. So in the angiotensin 2 mechanism, you won't be able to vasoconstrict here. You still get the afferent arteriolar vasodilatation, but you won't get the efferent vasoconstriction. And so therefore you won't get the full increase in hydrostatic pressures here as well, and your GFR will be lower. Now, it's still controversial. This probably leads to worse outcomes. It's controversial whether this leads to worse outcomes. So I'm going to touch on that a little bit later about whether ACEs and ARBs are, despite the creatinine rises and the evidence of the AKI, are they maladaptive or not, right? So in the situations of pathology. What about liver disease, right? So let me kind of like shift. So we talked a little bit about just the general physiology of AKI. I wanted to touch on AKI and liver disease because there has been some progress and some change over the past 5 or 6 years. Um, and I also wanted to highlight the kind of some of the misconceptions in AKI and liver disease, right? So it's you have to understand the base rates of these conditions and what are common and what's not common. And oftentimes when I'm on the nephrology service, if anyone with cirrhosis and they have AKI, the consult's asking is how do you manage this HRS? And I have to go back and step back and say, okay, wait, we haven't made this diagnosis of HRS or hepatorenal syndrome. Hepatorenal syndrome is a diagnosis of exclusion. You have to make sure that the patient is volume replete, so they've received volume, because you have to remember these liver disease, these cirrhotics especially the advanced cirrhotics, they're on lactulose, they're on diuretics, right? So they're getting paracentesis up to 6 to 8 liters at a time. And so and their nutrition, their PO intake often can be impaired. So they have a lot of reasons to be intravascularly depleted. So you have to make sure the patient's volume replete. You should likely spin their urine and see if there's ATN, right? So ATN takes time to recover. And so if you see muddy brown casts on your in your microscopic UA, and then at that point you might want to say this patient has ATN, right? It doesn't mean that you don't have concurrent HRS. ATN is something that occurs secondary to something else. You have to find what led to the ATN, but that doesn't necessarily mean you have HRS at that point. You could have AIN, right? These patients are often on antibiotics. And then also don't forget your glomerular syndromes, right? So IgA nephropathy is the most common type of glomerulonephritis that occurs in patients that are cirrhotics, right? So that's something you don't want. If they have Hep C, think about cryoglobulinemia. This is why you always want to get that UA. If the UA is bland, then it's unlikely, right? So if there's no hematuria, there's no proteinuria, it's not going to be any of these glomerular syndromes. That's an easy way to rule that out. But if you have hematuria and you have proteinuria, and they're not diabetic, right? So they have no other reasons, or they don't have bladder disease or something, some other reason to have hematuria, or they didn't have a fresh Foley that might have caused some trauma. Then you might want to be considering these syndromes as well. So as far as like diagnostic criteria for HRS, so I've mentioned some of these before, right? So obviously they have to have liver disease. The criteria for AKI has they've now made it similar to the KDIGO criteria, just to have a consistent way. So again, 0.3 in 48 hours, right? So it's kind of the magic number there. And then they have the urine output criteria as well. You have to have no full or partial response to volume, right? So they talk about 2 days of diuretic withdrawal and volume expansion. Now, I kind of have issues depending on where you are. I have an issue with this criteria because we are getting into this, especially where we practice, and Dr. Puri will mention this as well, is that we have access to ultrasound and we have access to hemodynamic monitoring and things like that. And so, if you it just even just an ultrasound, you can check in an IVC, right? So if the IVC is which is not the end all. Again, I could do a whole lecture on just IVC physiology. But if the IVC is big and dilated for whatever reason, right, RV dysfunction or something like that, which is not a low incidence, uh, cardiac disease in liver patients, it's not a low incidence situation. So if you have a dilated IVC, you probably could skip this step because that's just telling you that your CVPs are already high. You already have venous congestion, and that this volume is probably going to make this problem. And again, you're wasting 2 days, right, in a patient that's very sick and giving the albumin or crystalloid, right? So I do have an issue with that. But again, I think for most patients, this is probably fine. But if you have an ultrasound, you could potentially even skip this step, I think. The absence of shock. This is difficult, right? So most of these patients that are sick, hepatorenal physiology is very similar to septic physiology. You have vasodilatory state, right? And so this is difficult, or the absence of shock. But they also have a very high incidence of sepsis, right? These cirrhotic patients there. So it's a kind of a muddy picture. It's kind of difficult to navigate sometimes. And then no concurrent or recent treatment with nephrotox. That's also very difficult, right? These patients are on chronic, like on antibiotics and SPP prophylaxis and things like that, right? So and they're on diuretics, and which are not directly nephrotoxic, but you can become intravascular bleeding and cause nephrotoxicity. And then I mentioned this, right? So the absence of parenchymal disease, just a simple UA. If you don't have hematuria, you don't have proteinuria, it's not any of the glomerular diseases. So you have to have absence of that. Now, with the caveat being diabetics can have proteinuria, but they can, if they're cirrhotic, because the incidence of diabetes is so high, if they have concurrent cirrhosis, there's a probability that this person is going to have some proteinuria, and you won't need to take this into context. It's unlikely to be GN. So if you have bad uncontrolled diabetes and retinopathy and things like that, and there's proteinuria, you probably want to say it's from the diabetes. And then just the suggestion of renal vasoconstriction, because in hepatorenal syndrome, you're very systemically vasodilatated, but you're locally vasoconstricted in the renal to maintain perfusion, like the mechanisms we talked about earlier, right? So you're locally vasoconstricted. And so if there's suggestion of renal vasoconstriction, meaning that the FeNA is less than 0.2%, there and without any other cause, like a poor pump, like cardiac failure or something like that, and that's also suggestive. Now, again, this is not specific to it, but if you have that, it will support your diagnosis, especially after you volume repleted the patient. And there's HRS1 and HRS2. Like these are kind of the new classifications. They're calling this HRS AKI and then HRS non-AKI, or just chronic HRS chronic kidney disease. So you can HRS AKI, the type 1. This is essentially without a liver transplant. This is that patient is probably going to have a poor outcome, right? They need a liver transplant. HRS2, you could probably manage chronically, but at some point they need to be put on a list for a liver transplant as well. So the pathophysiology of kind of the overall like mechanisms of why you're leading to AKI in this situation, it's very similar to sepsis actually. So the patients with portal hypertension, liver failure, they have an increased predisposition to bacterial translocation from the gut, right? They have gut edema and things like that. So there's the PAMP release, right? So the pathogen release, the PAMPs and the DAMPs, right? So it's the common sepsis physiology type thing. And so they will have activation of the innate host response. And at that point, the cytokine release and vasodilatory state. So again, the HRS physiology is so similar to sepsis because partially it is sepsis. And so you have this vasodilatory state. And then when your vascular resistance falls that much, perfusion will fall as well. And so at that point, you'll be predisposed as other organs become dysfunction. You'll have predisposition, hepatic encephalopathy, and adrenal dysfunction. And adrenal dysfunction they have a higher incidence in cirrhotics than they do the average population. That's something that you really need to be thinking about as well. And then obviously you'll get renal dysfunction as well. Let's move on to abdominal compartment syndrome. So this is probably really underdiagnosed. And so what we have to realize is that intra-abdominal hypertension, abdominal compartment syndrome, it's a spectrum, right? It's not an end-all binary as you worry about it when the intra-abdominal pressure is greater than 20, meaning it's abdominal compartment syndrome, but you don't worry about it when it's 18, right? So it's a spectrum and 18 can be dangerous, 12 can be dangerous. So theoretically, assuming a normal perfusion pressure and a normal MEP, you can have AKI with intra-abdominal pressure greater than 12. Now, I guarantee you, post-resuscitation, just sepsis patients, if you go around the ICU, start measuring their abdominal perfusion pressure, their intra-abdominal pressures, there will be a non-significant amount of patients that have intra-abdominal pressure just greater than 12, just because of resuscitation, right? So you have to remember is that over-resuscitation can predispose to this. So the way you want to think about it is not just the intra-abdominal pressure, but the abdominal perfusion pressure. The abdominal perfusion pressure goal is going to be greater than 60. And how do you calculate abdominal perfusion pressure? Is MAP minus intra-abdominal pressure. I think this trial probably needs to happen, but I think abdominal perfusion pressure may actually be a maybe more predictive of outcomes than just following a map, right? So it's closer to what these essential organs in the abdomen are feeling than what just the map would tell you. So if you have an intra-abdominal pressure of 15, but you're maintaining maps of 65 with pressors, you're not perfusing adequately. Your abdominal perfusion pressure is 50. It's not at goal. So either you need to figure out a way to reduce the intra-abdominal pressure, or you need to raise the MAP, right? So you might need a higher MAP and more pressors at that point. So I think this is something that needs to be studied more. But if you have pressure greater than 20, you need to figure out how to fix this, right? Do you need a drain? If there's big ascites, you drain it. You can put you can put a catheter in just to drain, consider like a thoracentesis catheter in, right? Just to keep it draining. You can have, the main thing is also you need to call surgery and see if they need to have, they need to be opened up, right? To relieve the pressure or not. So urgently, non-urgently, most likely if its pressure is greater than 20, if they're on the ventilator, their peak plateau pressures are high, there's no organ failure, their lactate is high, that they probably need to go surgery. And none of your interventions will probably be helping at that point. But other things you can do to support this is if the patient's on mechanical ventilation, you can paralyze them, you can remove volume. If they're on dialysis, try to remove volume that method. If they're still have urine output, diurese them. So All these things are potential mechanisms. You could, if they have an ileus, try to maybe potentially put a rectal tube in and have it on suction. So there's a few things that you can do to kind of improve kind of the number, but surgical consults is definitely a must. Um, so what are the clinical settings of abdominal compartment syndrome? It's trauma patients following massive volume resuscitation, right? This is a pretty common one. Massive ascites, post-liver transplant. The ascites is interesting because as a nephrology fellow, I worked at a center where they had a liver ICU. And so just kind of to my own little personal study, I would just walk around sometimes and just measure the intra-abdominal pressures of these patients. And out of the 20 patients in the ICU, at least 50% of them would have criteria consistent with elevated intra-abdominal pressures just at baseline, right? So it's fascinating, and I'm sure that's affecting their renal function as well. Bowel obstruction, pancreatitis is a really, for us, like as far as like a medical intensivist, which I primarily I take care of surgical patients as well, but medical, like pancreatitis is a big one for us, right? So systemic effects of increased abdominal pressure. So you have cardiac effects, you have GI effects, but when you have intra-abdominal pressures, it's an obstructive shock, right? So if you could think about it, is that when your intra-abdominal pressures are higher than your CVP, it's compressing. So let's say your CVP is 12, or your intra-abdominal pressure is 15. Now you've completely compressed that IVC, and venous return is completely impeded, right? And so venous return is impeded, your cardiac output's going to a decrease, and overall perfusion is going to drop as well. And this talk could be a talk in itself, and we could talk about how we can go back to that slide of the renal physiology, and we can talk about another 20, 30 minutes of how this affects the kidney and overall, right? Just the intra-abdominal pressure part of it. But again, we're time limited, but this is a fascinating subject. Other signs you'll see is if they're on the ventilator, the intrathoracic pressures will be higher, the airway pressures will be higher, the peak plateau pressures will be higher. There's there's a lot of controversy about whether these patients should be paralyzed or not. Honestly, I don't think it's a must to be paralyzed. They need to be passive though. They need to be passively breathing. So if you on adequate sedation, the patient's calm, you can take that intra-abdominal pressure, and then decrease splanchnic perfusion, the CNS effects as well. And then obviously just the renal and the eventual AKI that you're going to get because of all these mechanisms. You'll have venous congestion, you'll have compression of the kidney itself. The pressures in the Bowman space will rise, so that difference in the hydrostatic pressure in the capillaries versus Bowman space, that gradient will be less, so your GFR will drop as well. So lots of effects. So I think we're getting to 7:40. Just quickly, we'll try to go through a few cases, and then we'll take some questions. So we have a 74-year-old female, CKD stage 3. And so obviously already has kidney disease, has AKI, has heart failure with reduced ejection fraction, so EF's around 25%. The patient presents to the hospital, what looks like a CHF exacerbation. You're consulted on day 2. She's responding to intravenous diuretics, 100 milligrams BID. You have good urine output, negative fluid balance. Her creatinine is up to 2.5 this morning. So she is awake, feeling good. She's on 3 liters nasal cannula. She's on an ARB, beta blocker, no inotropes, and her lost cardiac index was 3.1. So let's say she had a swan in as well. But when her CVP was about 21. So with the cardiorenal syndrome, right? So with the this is obviously, so you have a CHF exacerbation. And then if you're looking at the question in regards to this case, which parameter is most likely associated with increased risk in this AKI? The biggest number that just kind of sticks out to me more than anything else is the CVP. CVP is probably the most predictive, like your right-sided pressures, venous congestion is probably most predictive of AKI of just about any parameter. And so the answer to that would be CVP. The physiology in cardiorenal syndrome is fascinating as well. Just that, again, just time limitation. But what we found is that the left side, so the picture of the venous congestion, is actually more important than the right side with the decrease in cardiac output. So it's fascinating. The venous congestion may actually be the more predictive of death than cardiac output actually is. In animal models, right? So if your sodium excretion, GFR, and renal blood all drop when your venous pressures rise, much more quicker than if you were to drop their cardiac output. And as soon as you fix that, it recovers quite quickly as well. When they look at patients, this was a really fascinating study. When they looked at heart failure patients with they broke them up into cardiac output, so high cardiac index and CVP. And what they found was that high cardiac index, low cardiac index, but when patients had high CVP, they're different. The outcome difference wasn't very different, but the biggest increases in outcomes is when your CVP rises, right? CVP was much more predictive of outcome and death than of AKI in general than your cardiac index was, which is completely it's not what I was taught when I was in training and I was learning as a resident or a medical student. So this was a fascinating kind of like finding that's gaining more and more traction now. So what about ACEs and ARBs in type 1 cardiorenal syndrome? If the ACE and ARB is indicated for chronic heart failure, you should try to keep it as much as you can. You need to try to keep it because the benefits of it are significant, right? So the benefits of it are significant. Guidelines say you should tolerate up to around 50% increase in serum creatinine. So when you look at AKI, you want to break it up into induced AKI and spontaneous AKI, right? If your creatinine rises 0.3 because you're decongesting someone, and that can happen, right? The rate of fluid removal might be faster than the rate of vascular refilling. And so you might have some AKI. But that is not a reason. If you've deemed this patient to still be venous congestion, still be in active heart failure, that is not a reason to stop, right? RAS inhibition. If you're initiating an ACE or an ARB and you have a 0.4 increase in creatinine, that's not a reason to stop. There's actually evidence that when you see this creatinine rise, the outcomes are better, especially in heart failure, because that means that it's working, right? That efferent arteriole is adequately vasodilated, the angiotensin is adequately being blocked, intensive BP control, and the newer the SGLT2 inhibitors as well, right? Its outcomes are better when it's induced AKI versus spontaneous AKI. So untreated cardiorenal syndrome, sepsis, nephrotoxin, or hepatorenals. I think we are running out of time, so let me just kind of open things up for questions at this point.
All right. Thank you, Dr. Sharad, for that. My apologies for not being able to introduce you properly in the beginning. I was having technical issues there. But that was an excellent talk. I mean, very informative with some great pearls for practice, diagnostic criteria. I think it was very useful. We have a few questions in the chat, and if somebody wants to ask any questions, please do raise your hand and I can unmute you. But Dr. Puri, before he left, he asked actually this question, which I also had in mind, is what is the role of ultrasound in the care of a patient with AKI? So what would you look for in your?
Yeah, this is this is a hot field right now. This is a really kind of like burgeoning, growing field. I think ultrasound is essential when you're managing AKI. So when I have a patient with AKI and it's undifferentiated and there's no obvious causes, I always do an ultrasound because whatever there may be an additional nephrotoxic reason, but there could be a concurrent venous congestion reason as well, right? So if the patient has a big dilated IVC, there's other methods called VEXUS, which is a venous excess score. I'll do a venous excess score if IVC is dilated. And so that will tell me how much venous congestion. This patient may have been on aminoglycosides, or they may have AIN, or they may have other reasons for AKI, but they may have concurrent venous congestion. I'll be diuresing their patients as well as taking away those other nephrotoxic agents. So that it really helps me really kind of narrow down what the AKI pathophysiology is and whether there needs to be additional kind of volume management as well. So I think ultrasound is essential for AKI management.
Well, thank you. So the next question, how would you measure intra-abdominal pressure?
Yeah, usually you would use it with Foley, right? So with the Foley, you would put in 25 to 30 cc's, and usually it's a protocol. And at that point, it's the same as measuring CPP. You connect it to the pressure transducer, and then you're seeing the kind of the variations. And so at that point, it's just like measuring the, and you would measure the intra-abdominal pressure at that point with the Foley. And so there's Foley, and it requires specific Foleys to measure. It has a pressure manometer on it, but you need a specific Foley to measure the intra-abdominal pressure. One thing that I want to work on in the future is non-invasive signs of intra-abdominal pressure using ultrasound, but that's still to come. It's still speculation at this point.
We'll wait for that. What is your comment on the role of traditional herbs or herbal medicine in causing AKI?
Yeah, it can happen, right? So there are this whole section, like if you were to go to, sometimes I teach some nephrology board review. You can spend an entire lecture on herbs and AKI. That doesn't mean that herbs are bad, but just when you have kidney disease or you're predisposed to kidney disease, there are, so for example, like a lot of herbs in India, there's concurrent lead, there's lead in it. And so it's the lead poisoning that leads, not the turmeric, but it's the lead due to improper handling and processing that causes AKI. So these are just things that we have to be aware of, is that it may not be the actual herb, but you need to know where regional differences in how these things are managed. Now, and it's coming out there, incidence of AKI in India has gone up because of and along with incidents of like brain, like CNS issues and things like that. But it's you have to be aware of that. So yes, herbs definitely. And I would never, when patients ask me about herbs, I never say that they shouldn't take them. But I would just say let's do our research and make sure, given your disease process and given the medications that you're on, we need to be very careful about what you're taking in.
Yeah, yeah, and we do see a lot of patients with AKI who we then probably attribute them to herbs. So yeah, it's a growing
Okay.
problem.
Okay.
Yeah. So another question is there any role for urine microscopy in AKI in the ICU? And will this assist
Yes.
in diagnosis of hepatorenal syndrome?
Yeah, I mean, urine microscopy, if you have the ability to do it and you're proficient at urine microscopy, you, for example, like if you have someone and you're resuscitating them, they're still hypotensive, but you see ATN, like you see muddy brown cast on the urine microscopy, that might be saying is that you have a faucet, that faucet is closed, there's nothing coming out. Any additional volume you're giving is just going to be sitting in the body. And that may cause more damage over time, more venous congestion, more interstitial edema. So that can completely change your management at that point, right? So urine microscopy is so helpful. Like for example, again, if you saw hematuria and proteinuria, right? You may have hematuria from Foley damage, for Foley trauma, but you do the microscopy and you see evidence of RBC casts, you've changed your diagnosis and your differential at that point, right? So if you have the ability to, you should, if an AKI is not obvious, like obviously if someone comes in with septic shock and they don't have many comorbid diseases and they have AKI, it's probably because of the septic shock, right? It's just most likely that's the physiology. But if most patients aren't as simple as that, so yes, urine microscopy can be very, very helpful.
And how would you differentiate between ATN and AIN as a cause of AKI?
Yeah, so yeah, AIN is a difficult, it's a difficult diagnosis to make. So again, urine microscopy will be very helpful. If you are doing urine microscopy, see muddy brown cast, you have ATN, right? Now AIN, you need some sort of kind of like trigger, usually like antibiotics, right? This patient was on antibiotics for the past 2 weeks. That can cause AIN, right? So or allopurinol or something like that. And so you need to have some triggering thing. You could check a urine for pyuria. We used to say eosinophils. Eosinophils have been kind of debunked as kind of a way to diagnose AIN. Yeah, I would say as far as negative predictive value, if you don't have pyuria in the urine, you probably don't have AIN. Again, the gold standard is kidney biopsy. If you're still not sure, the patient with antibiotics, they don't have muddy brown cast, the kidney's getting worse, the creatinine getting worse, you could potentially either empirically just give them steroids because there is some evidence for steroids for AN, or you need to get a kidney biopsy at that point.
Right. Maybe we have time for one question. Can you comment on the management of AKI in severely malnourished patients with hypothermia?
In severely malnourished patients with they're more predisposed. The hypothermia part, that part, it probably, I don't have a clear answer that how the hypothermia would be affecting it. The hypothermia would be affecting it in the way probably of like what your vascular resistance is doing is what your heart rate's doing. So when you're hypothermic, your heart rate will drop and potentially your cardiac output will drop too as well. But the malnourished patient, that person is predisposed, right? So any volume they're getting, they're most likely going to get more capillary leak. They probably have more chronic inflammation. So all those things, but they're probably more predisposed to AKI.
I think we've gone through the questions. Just some comments in the chat box.
Oh, I see about the NSAIDs. Yes, yeah, that's a great point, right? So the orthopedic surgery might be getting more NSAIDs after and the rhabdo and things like that. 100%, right? That's a great point.
All right. Okay, well, thank you everyone. I think that was great. That was excellent. Thank you, Dr. Patel.
My pleasure.
Early morning webinar for you, but we are very
Oh, it's okay.
yeah, we're
Not a
grateful
problem
for
at all.
that, and
I'm just happy my kids were quiet and upstairs in the background.
yeah, that's great. Yeah, thank you so much, and
Thank you.
I speak on behalf of everyone here, and I also thank everyone for attending, and we hope we'll see you again in the next webinar.
100%. I hope to make the trip there next time with
Oh, yeah.
Dr. Pura.
Definitely. Would love to have you here. Yeah.
Have a good one.
You too. Take care. Thank you.